think will give you some great insights into how to apply the KCC knowledge to your transplant patients. Thanks, Habib.
Thank you, Dr. Landsberg. Hello, everyone. I'll be talking about the management of the failing graft, focusing specifically on chronic kidney disease considerations. So no disclosures or conflicts of interest. The outline of the presentation will be as follows. First, I'll talk about the burden of CKD, kidney transplant recipients. Then I'll focus on selected CKD-related complications, specifically hypertension, anemia, and mineral metabolism. So for each one of these, we'll cover briefly mechanisms of pathogenesis and principles of management within a transplant setting, of course. Then we'll talk about preparation for renal replacement therapy. So I'll talk about dialysis only. Dr. Landsberg will be talking about re-transplantation in the next talk. And then briefly, we'll talk about ways to optimize CKD care in the kidney transplant recipients. So according to recent registry data from the Scientific Registry for Transplant Recipients, the average estimated GFR 1 year post-transplantation is about 56 milliliters per minute. And this is roughly the same for live donors as it is for deceased donors. So there's been significant improvements compared to the 1990s when the 1 year GFR was about 50 milliliters per minute. However, in the last decade, this seems to have reached a plateau. This is because while there has been and there continues to be improvements in transplant care, at the same time we are transplanting more elderly recipients and accepting more marginal deceased donors. So what's important to recognize from these figures is that at 1 year post-transplantation, many of our kidney transplant recipients will already have stage 3 CKD or worse. So this table is from the KDIGO guidelines, and it summarizes some of the most common complications associated with impaired kidney function. And we can see that the prevalence increases with the level of kidney dysfunction. And I'll remind you that most of our patients already at 1 year will be in this part of the table. So we can see that there are significant proportions of anemia, hypertension, vitamin D deficiency, metabolic acidosis, hyperphosphatemia, hypoalbuminemia, and hyperparathyroidism. So these figures are from CKD cohorts at large. They didn't look specifically at transplant recipients with failing grafts, but there are a lot of studies that support this statement that kidney transplant recipients and native CKD patients have similar complications according to the level of severity of their kidney dysfunction. So we'll start by talking about hypertension. So post-transplant hypertension is extremely prevalent. The reported rates vary from 75 to 90%. And again, the prevalence increases with the level of kidney dysfunction. It's a recognized risk factor for allograft loss through both chronic allograft nephropathy, but also through cardiovascular disease, which is an important cause of death with a functioning graft. And the importance of post-transplant hypertension is very well illustrated in these survival curves. So to the right, we have death-censored graft loss, and to the left, we have all-cause graft loss, including death. On the x-axis, we have the number of years post-transplantation, and on the y-axis, the proportion of functioning graft. So what we can see is that the curves are a lot steeper as the systolic blood pressure increases. And this systolic blood pressure is measured at 1 year post-transplantation, and it's the same for both all-cause graft loss and death-censored graft loss. So from this same study, they also looked at diastolic blood pressure, and the findings were the same. And they looked at blood pressure at 3 years and at 5 years post-transplantation, and the curves were also very easy to distinguish. So the etiology of post-transplant hypertension is multifactorial. In any given patient, it's a contribution of one of these factors, either immunosuppression, graft disease, including impaired graft function, recipient factors, including essential hypertension, and donor factors. So this diagram summarizes the mechanisms by which immunosuppression can mediate post-transplant hypertension. So there's a complex interplay between reduced EGFR, between sodium retention, vasodilation inhibition, and vasoconstriction. The calcineurin inhibitors have been shown to increase sympathetic nervous system activation, to upregulate endothelin, and to inhibit nitric oxide. This has for effect a systemic vasoconstriction and brings about or exacerbates existing hypertension. Steroids, on the other hand, also contribute to vasoconstriction, but they have a mineralocorticoid effect and through sodium retention can contribute to hypertension. So for the management of post-transplant hypertension, at present, the targets recommended by the Canadian Hypertension Education Program are as follows. So less than 140/90 for non-diabetic kidney transplant recipients, and a lower target, less than 130/80 for diabetic kidney transplant recipients. There's no evidence to target lower numbers for patients with proteinuria. So to attain these targets, the first thing to do is to optimize non-pharmacologic interventions, so lifestyle changes, weight loss, regular exercise, sodium restrictions. And for pharmacologic interventions, just a couple of considerations. So the choice of antihypertensive agent is usually dictated by comorbid conditions and adverse effect profile. Usually a combination of different drugs is required to reach targets. Drug interaction is important to consider, especially with non-dihydropyridine calcium channel blockers and calcineurin inhibitors. Dihydropyridine calcium channel blockers are the agents most often preferred because they have been shown to minimize CNI-induced vasoconstriction. They have a proven efficacy, and they are well tolerated by patients. At present, there's no definitive evidence with respect to long-term graft function and allograft loss with RAS blockade. So they remain a good option, but they should be used with caution because of the risk of hyperkalemia and acute kidney injury. So as I mentioned, for each class of antihypertensive agent, there are advantages and disadvantages to consider. And for the individual patient we want to treat, we should weigh these two sides of the treatment and make our choice accordingly. So moving on to post-transplant anemia. The reported prevalence varies according to the definition used, but in long-term kidney transplant recipients is estimated to affect 30 to 40% of our patients. So the most important risk factor for anemia is impaired graft function, but pathogenesis remains complex and multifactorial. So it has been associated with impaired cognition, reduced quality of life, and decreased exercise capacity. However, with regards to hard outcomes, there's conflicting results. There's no consensus that anemia post-transplantation is independently associated with increased graft loss, mortality, or adverse cardiovascular events. This is because the available evidence is mostly observational, so there are a lot of inherent biases and unmeasured confounders. So at present, it's not clear whether anemia has direct pathogenesis or if it's a marker for an underlying pathologic process. So as mentioned, decreased graft function is the main driver of anemia post-transplantation, but it is only one cause among many others. And it's important to consider all causes when treating anemia in a transplant patients. So these causes are usually classified as either decreased red blood cell production, increased red blood cell destruction, or loss of red blood cells. And I'll just bring your attention to the importance of drug-related anemia, whether it be immunosuppression or antimicrobial prophylactic agents, through both decreased RBC production and increased RBC destruction. So for the management of post-transplant anemia, for reasons not completely understood at the time of dialysis initiation using USRDS data, kidney transplant recipients with failed grafts seem to have similar rates of anemia compared to general ESRD patients, despite more frequent EPO use. So to the right, we have the percentage of EPO use, the white columns corresponding to transplant patients, and the gray columns to native kidney patients. And to the left, we have the hematocrit with proportion of patients. So it's not completely understood yet why there is this difference, but it might be because there are so many other causes for anemia in transplant patients. So pending specific data from transplant trials, the CST-CSN work group recommends that anemia should be managed in a similar manner to patients with native CKD. So this means iron supplementation in patients with a TSAT less than 30% and serum ferritin less than 500, and erythropoiesis stimulating agents when hemoglobin is below 90 to 100, targeting acceptable range of 95 to 150. The challenges in the transplant patient include some of the following points. So the use of serum ferritin levels in the setting of chronic inflammation, so that could lead to under-recognition of iron deficiency. And chronic inflammation and immunosuppression may decrease erythropoietin efficacy. And as I said, it's also very important to consider other causes than impaired graft function for the anemia. So now let's move on to metabolic parameters. So this is a cross-sectional study looking at close to 2,200 kidney transplant recipients followed in 4 Spanish hospitals. So we can see the typical findings of calcium and phosphate abnormalities that we see in CKD. So there is hypocalcemia, hyperphosphatemia, and hyperparathyroidism. We can also see the metabolic acidosis. So all these parameters increase with the level of kidney dysfunction and have significant proportions in the impaired graft. So with impaired graft function, there's a reduced glomerular filtered phosphate load and decreased phosphaturia. Levels of FGF23 and PTH increase in order to stimulate phosphaturia, but given that GFR is reduced, this results in hyperphosphatemia, hyperparathyroidism, and high levels of FGF23. So the mechanism is similar to CKD native patients. So this is a graphical overview of the hypothetical course of serum phosphate, parathyroid hormone, and FGF23 levels in patients with CKD undergoing kidney transplantation. So from the time of transplantation until graft failure. So before transplantation, circulating levels of all 3 of these parameters increase in parallel with renal function decline. At the time of transplantation, patients may have excessively high levels of FGF23 and PTH. After transplantation, there is a recovery period where FGF23 and PTH can remain high for months despite restored renal function. This effect might contribute to the development of post-transplantation hypophosphatemia. After the recovery period, all these parameters might return to the normal range, although PTH can remain high. In the case of tertiary hyperparathyroidism. And with impaired graft function, levels of all 3 of these parameters can increase again, starting with FGF23, observed in the pre-transplantation CKD setting. So why are these parameters important to look at and to correct? Well, long-term exposure to hyperphosphatemia and high levels of FGF23 may have adverse effects on the cardiovascular system, kidney, and bone disease in kidney transplant recipients. And we know that a high level of serum phosphate, calcium phosphate product, or FGF23, have been independently associated with an increased risk of graft failure. So what should we do about that? So non-pharmacologic interventions once again. So data specifically addressing the effect of dietary modification on phosphate metabolism after kidney transplantation are scarce. However, dietary interventions might reduce phosphate toxicity and FGF23 levels in patients with impaired graft function. For pharmacologic intervention, caution with non-calcium-based phosphate binders, as they may reduce the peak of concentration and area under the curve of mycophenolate. Efficacy and safety trials are lacking in kidney transplant recipients to be able to recommend calcium versus non-calcium phosphate binders. And calcium supplementation and vitamin D analogs are important to use to decrease PTH levels. So now changing gear, we'll talk about planning transition after graft loss, specifically dialysis. So as Dr. Johnson said, repeat transplantation and preemptive transplantation is the preferred option for most kidney transplant recipients. However, an increasing number of patients are returning to dialysis after graft loss, and it is now in the top 5 leading causes for dialysis initiation. And it is associated with high rates of morbidity and mortality. So this graph illustrates well this last statement. So compared to age-matched native kidney patients, those with a graft initiating dialysis had more frequent admissions to hospital. So the percentage corresponds to the proportion of patients being hospitalized at least once in the first year post-transplantation. And the number on the x-axis corresponds to the average number of hospitalization per patient. Is there a difference between modalities? I couldn't find any article to suggest that there is. This is data from the Canadian Organ Replacement Registry that looked at close to 2,200 patients over 15 years that initiated dialysis after graft failure. So most of these patients will go to hemodialysis, although there is a non-significant proportion that will go to peritoneal dialysis. And this study showed that early, late, and overall mortality were similar for PD and HD. So transition to hemodialysis, access referral is extremely important. So this study using USRDS data looked at patients from 2006 to 2011. There were close to 17,000 hemodialysis starts after graft failure and close to 500,000 hemodialysis starts in patients with native kidney failure. So the rate of initiation with a central venous catheter, so a non-permanent vascular access, was better in the failing transplant population, so 65% compared to 81%. However, many authors agree that this is not as good as it should be for many reasons. One of the reasons is that it's important to consider that many of the suboptimal dialysis starts in the native kidney ESRD population are attributed to late nephrology referral, whereas transplant patients are presumed to have specialized care from day one. And another important point with regards to vascular access, infection is the second leading cause of morbidity and mortality among hemodialysis patients. And central venous catheters continues to be the main driver of infection in the hemodialysis population. So patients initiating hemodialysis after graft failure seem to be at an even higher risk because of previous or ongoing immunosuppression, or because of the presence of the failed renal allograft as a source of inflammation. So this highlights well the importance of timely creation of a vascular access in the failing graft population when hemodialysis is the chosen modality. So the timing for dialysis initiation. So some studies suggest that kidney transplant recipients initiate dialysis later than they should. This bar graph uses USRDS data and shows the estimated GFR at the time of initiation of dialysis in kidney transplant recipients and the general ESRD population. So the white bars correspond to kidney transplant recipients and the gray bars to the general ESRD population. So on average, kidney transplant recipients initiated dialysis at an earlier GFR at 8.4 milliliters per minute compared to 7.8 milliliters per minute. So it's hard to determine just from the GFR if timing of dialysis is optimal or not. And this is because decision to start dialysis, as you know, is based on symptoms and signs of uremia rather than a GFR cutoff. However, what we can see from this graph is that a significant proportion of patients are starting below 6 milliliters per minute, which is the recommended cutoff by the CSN, regardless of the presence or not of symptoms. So there is no difference between the general ESRD population and failed kidney transplant population. However, many of the authors in the articles that looked at this claim that kidney transplant patients should be held to a higher standard. And this is because they are presumed to already have specialized care at the time of dialysis initiation. So keeping that in mind, we'll just look at albuminemia at the time of dialysis initiation. So albumin is at the time of dialysis initiation is comparable in the kidney transplant recipients and general ESRD population, and this is data as well from the USRDS. We know that hypoalbuminemia is associated with worse nutritional status and adverse outcomes. However, it's important to keep in mind that albumin is a late marker of malnutrition, and in kidney transplant recipients, many other contributing factors should be considered. So this highlights the importance of assessment of nutritional status, which often requires the expertise of a dietitian. So, in summary, management of CKD-related complications in kidney transplant recipients seem to be inferior to native CKD patients. So I didn't present all the data to support this statement, but a lot of articles seem to point in that direction. We also saw that preparation for dialysis seems to be suboptimal despite prolonged follow-up and specialized care. So there's higher than expected rates of dialysis starts with a non-permanent vascular access, and there's inferior CKD parameters at the time of dialysis initiation. So there's a lot of hypotheses to explain these differences, and there's no clear answer. Probably they are all contributing factors. So is it that there's an under-recognition of CKD-related complications in our transplant population because the main focus of our visits is on the immune part of management? There is an added difficulty in achieving therapeutic goals in transplant recipients because of immunosuppression, chronic inflammation, and non-adherence. There's also the fact that these patients have accumulated time with CKD end-stage renal disease, which makes them maybe more difficult to manage. There might be some problems with adherence or polypharmacy, as we said. And is it because there's no recent guidelines specific to the management of the failing graft? So this slide is just meant to show the care model that is used in native CKD patients and which would be beneficial as well in the transplant setting, involving the expertise of many health professionals. So we saw the importance of non-pharmacologic interventions, and we saw the importance of interactions in medications. So of course the expertise of all health professionals are important to improve care in the failing graft and optimize management. So just some key points. At 1 year post-transplantation, many kidney transplant recipients will already have advanced CKD. Optimal pre-ESRD care includes intervention that delay progression, prevention of uremic complications, and preparation for renal replacement therapy. Kidney transplant recipients and native CKD patients have similar complications according to the level of severity of kidney dysfunction. There are transplant-specific considerations for CKD-related complications with regard to pathogenesis, differential diagnosis, and management. Optimal preparation for renal replacement therapy includes timely education, choice of modality, and access creation, and dialysis initiation. And the multidisciplinary care model used in CKD patient has great value in optimizing care for the failing graft. So thank you all.